the thoracic outlet syndrome. We're going to define the thoracic outlet syndrome and identify its causes. We're going to define the clinical manifestations and the functional limitations of thoracic outlet syndrome. We'll discuss the tests and measures, discuss the differential diagnosis, we'll discuss the rehabilitation intervention phases, and the possible outcomes. The thoracic outlet is an anatomical space supported by the first thoracic rib, the clavicle, and the superior border of the scapula. This is where the great vessels and nerves of the upper extremity pass. Thoracic outlet syndrome, or TOS, represents many conditions and is defined as the compression of neural or vascular structures that pass through the thoracic outlet. TOS can be defined into three separate categories according to where the compression lies: neurogenic, venous, or arterial. Neurogenic TOS is the compression of the nerves of the brachial plexus at the scalene triangle. It's the most common, representing 95% of TOS cases. Venous TOS is the compression of the subclavian vein by structures making up the costoclavicular junction. Venous TOS represents 4% of TOS cases and is mostly present in men. Arterial TOS, which is compression due to the abnormal bony or ligamented structures at the thoracic outlet region, is usually the least common. And this is a depiction of the thoracic outlet and the structures that surround it. The pathomechanics can be either congenital, trauma, or functional in nature. Congenital causes can include the cervical rib presence or the anomalous first rib presence. So usually it's like an extra rib that's up in here. Trauma is usually from car crashes, so whiplash injuries, and also falls. And then functional causes are vigorous repeated activities that are usually associated with sports or work. And then some other causes are hypertrophy of the neck muscles, abnormal posture, hemorrhage or hematomas, displaced fractures, edema, malignancy, and pregnancy. So the clinical manifestations and functional limitations. So our signs and symptoms. Signs and symptoms of TOS can vary depending on the type of TOS, but they all generally have some common indicators. So dull, achy pain in the arm, neck, and shoulders, swelling of the arms and fingers, weakness of the arms and fingers, muscle atrophy of the hands, paresthesia in the fingers and hands, pallor and discolored skin, and decreased skin temperature. And pallor is the paleness of the skin. So then for our functional limitations, we have limited range of motion, decreased strength, easily fatigued arms and hands, postural dysfunction, increased symptoms with movement, improper head and neck alignment, and then difficulty with fine motor tasks. And this is just a depiction of what that discolored skin could look like due to the compression of the TOS.
For tested measures, it'd be important in any spine test to go through palpation and active range of motion first, but it would also be beneficial for thoracic outlet syndrome to test for in-field assessment. A lot of times with these patients going through certain motions, you have to be very careful, but getting to hyperflexion, maybe sometimes hyperextension and hyperabduction can bring on symptoms for them and could bring up an empty infield. Combined motions as well, you want to be very careful when assessing these motions, especially in the scapulothoracic motions, as well as glide assessments. A lot of times neurological stress tests will help indicate this as well, but the gold standard for testing and measuring thoracic outlet syndrome will be the special test, particularly RUSE, elevated arm stress test. I think we all remember this one with the 90 degrees of abduction and clenching your fist for 3 minutes. Normal would be fatigue in the forearm muscles. That's with 3 minutes of clenching your fist, you'll see that. But if they're starting to get their symptoms, a reproduction of their symptoms, maybe radicular pain or numbness and tingling in their fingers or even their forearm region, this would be a positive test for thoracic outlet syndrome. Another one would be Adson's maneuver. This one focuses more on the arterial and venous, mostly the arterial compression of the thoracic outlet syndrome, where you'll be extending and slightly abducting their arm while checking their radial pulse behind their back, keeping their elbow extended, and you'll be assessing for radial artery palpation. You'll be palpating that and seeing if it's a quality pulse or not. And for a differential diagnosis, since this is such a clinically complex diagnosis, there's a large variety of different presentations in clinic. So it could, I made a short list, but it could be a lot of different things you see in clinic that you would have to weed out. You could see complete and partial lesion of the plexus. This would be different because they wouldn't really see they wouldn't see any help. They wouldn't have any benefit or relief of their symptoms in any motion normally. Sometimes with partial lesion, but carpal tunnel syndrome and cubital tunnel syndrome will they won't present the same, but they're in the same regard of they normally can localize their symptoms either in the median nerve distribution or the radial nerve distribution. Normally, if it's severe enough, they can have symptoms that might clue you into thoracic outlet syndrome, but being able to go through your neurologic stress tests and seeing that they have a particular distribution would help differentially diagnose those two. Duquesne veins, a little bit similar in terms of when it's severe enough, it might present with neurological symptoms, the same as thoracic outlet syndrome. But this is also one that you can normally localize with the test we learned yesterday. And peripheral artery disease and other sorts of heart diseases, you can sometimes see that decrease in radial pulse when you're going through Adson's maneuver or assessing a different way of their blood flow, their vasculature. So some possible modalities in the maximum protection phase, something you want to emphasize early and throughout your treatment of thoracic outlet syndrome would be some kind of posture correction. Sometimes these patients have forward neck posture, or sometimes some kind of scapular deformities. That's something we'll also want to examine in clinic. So it would be important to maybe derobe these patients and check for any deformities of the scapula, the thoracic spine that could be causing this, because we might need to refer out if maybe this is something like Gabby talked about, maybe an extra rib, or maybe some kind of deformity that we can't fix. A lot of times we can correct some postural things that can help with this, but it'd be important to rule those out. Going through passive range of motion and active assist range of motion in the maximum protection phase. Some positional release techniques, if it's maybe tight muscles that are causing this compression. Neuroglides, if they're having a lot of neurological symptoms, we'll want to try to centralize their symptoms. If they're feeling tingling or numbness in their fingers, we'll want to move that radicular pain up and closer to the origin of that thing. That would be one of the goals of our treatment. In the second phase, the protection phase, moderate protection phase, we'll want to do moving into more active range of motion and resistive training if we're able to limit their radicular pain and their symptoms. We'll want to work on some breathing stability patterns. If it's possible, like they're stating in their history that when they're doing something where they're holding their breath or they take a deep breath in, they're feeling those they're getting a reproduction of their symptoms. Controlling their breathing patterns has been shown to help for these patients. Improving their cardio training if we can tell there's deficits in their radial or ulnar pulses. And then the return to function phase, starting to do some rhythmic stabilization, some PNF patterning to strengthen the muscles around that region. Doing some upper extremity plyometrics if they're capable of doing so. And then progression of their resistance training that we started in the moderate protection phase to strengthen the scapulothoracic muscles and the muscles in that region. So outcomes are very variation specific, with it being 3 different types of compression as well, and any combination of those. It could take longer. This is a very loose 6-week time frame, but typically about 6 weeks of non-operative intervention and posture correction could help an individual, but this is also individually specific, especially for the arterial and venous compressions. If someone came in with those that kind of thoracic outlet syndrome and also had a condition like diabetes, it would be a little bit more difficult and take a longer time to progress these patients. A major goal would be centralization of these symptoms, especially with the neurologic tissue. We would want to make sure that the brachial plexus was free and could move freely throughout the upper extremity into the thoracic region. And we should be trying to move those symptoms proximally to that area from either their fingers or wherever they're stating they're getting these symptoms, moving it back up centrally. And for the congenital, like what we're talking about, maybe even having surgery. Some of these we won't be able to free up because they could possibly have an extra rib. So there is surgeries where they will actually remove part of or the entire rib that's causing this compression. So quick overview, thoracic outlet syndrome is characterized by compression of neurological and vascular structures like the brachial plexus and the subclavian artery and vein due to muscle length tension or congenital reasons due to abnormal ligamentous or bony structures. Patients often present with an inability to sustain certain upper extremity positions for a long period of time without reproduction of their symptoms. They have difficulty loading, like holding something that might be a little heavy or just moving in general with their upper extremities. They often have pain, numbness, discoloration, and possible swelling. And this can typically resolve within like a rough 4 to 6 week period of interventions.
Okay, go back to your pathomechanics slide. You see cervical rib presence, anomalous first rib presence. So in many cases, these patients could have an elevated first rib to where they would benefit from mobilization of the first rib, like depression of the first rib, trying to reposition that first rib and where it should be. So that's going to be hallmark to assess for an elevated first rib, and I'll show you all that in the interventions course too, because what we use for interventions is ultimately an assessment that turns into an intervention. So I'll show you how to assess and compare bilaterally to assess for an elevated first rib. So it's good to notate that because that's one of the hallmark problems of thoracic outlet syndrome pathomechanics. Another one is abnormal posture, which is hallmark for anything that can happen in the cervical spine. So you always want to look at posture. Most of the time with these dysfunctions of the cervical spine, they're going to fall into 3 different categories: postural syndrome, derangement syndrome, or mechanical syndrome. most of the time your problems are gonna fall into one of those categories. So you look at posture and see if posture is the cause. You look at derangement. Derangement means that they have a symptomatic bulging disc or herniated disc that's causing ridiculous symptoms. That's derangement syndrome. And then mechanical, if there's a positional fault or either hypomobility or hypermobility. And we know as physical therapists, you can assess and treat that. So that's good that y'all pointed those things out on pathomechanics. Very, very good. All right, go to your differential diagnosis slide. A very, very important slide. So you have to know how to differentiate thoracic outlet syndrome from those conditions, because this is how they're gonna come at you on the National Physical Therapy exam. That's why I put this in your slide to do. And your classmates can go back and look at this, but classmates need to go back and read the text too. You go back and look at what's on the slide, study the slide, but go back to the text to confirm it. You wanna actually put your eyes on the content. But like you said, carpal tunnel typically localized, Dacquevians typically localized. Cubital tunnel can be tricky, but you gotta look at where the pain starts and ends. So most likely cubital tunnel is gonna start at the elbow, you know, and you can do a Tenel sign at the cubital tunnel to rule in or rule out if it's cubital tunnel. Then mostly peripheral arterial disease mostly impacts the lower extremities. So that's one that you can look at as well.